For this episode, I'm joined by Nichola Crust, who's the National Investigator for the Healthcare Safety Investigation Branch, the HSIB. Nikki led the HSIB report into the placement of nasogastric tubes that was published in December 2020 and is definitely worth a thorough read for anyone involved in the placement or checking of NGTs. Nikki is a nurse and has previously held a number of roles that relate to quality governance and patient safety, including Head of Nursing, Quality and Safety for NHS Leicester, Leicestershire and Rutland Alliance. Nikki has completed the Health Foundation's Generation Q Leadership and Quality Improvement Programmes and holds an MSc in Leadership in Quality Improvement. Nikki, welcome and thank you for coming on the NG podcast today to discuss your work with the HSIB and the report into nasogastric tube placement.
Thank you.
When we talked about this before, I actually sort of to you that the Healthcare Safety Investigation Branch sounds quite a scary title for an organisation. I almost feel like you should have a badge to show when you turn up. So can you tell me what the remit of the HSIB is?
So you're not the first to say that to me, Marcus. The title of the Healthcare Safety Investigation Branch follows other safety investigation branches. For example, the Rail Accident Investigation Branch, the Air Accident Investigation Branch. And hopefully when I meet staff and patients and their families, I'm able to allay their fears in this regard and not present my badge. So in answer to your question, HSIB conducts independent systemic safety investigations of patient safety concerns in NHS funded care across England. So we're funded by the Department of Health and Social Care and hosted by NHS England and NHS Improvement. And we do hope that obviously in time, when parliamentary time allows, we'll be established as an independent public body. You'll know from our conversations and also our report that we don't apportion blame or liability, and we value the transparency and the opportunity for learning for improvement. We work very closely with patients, families and healthcare staff. And indeed, in the branch, we have a family liaison lead who really does help us include the voice of the family in our investigations. You'll know from our report, we make systemic safety recommendations to national bodies to effect change across an entire sector rather than at a local trust level, which in my experience can be a bit frustrating when you know there's something that can be changed. The safety recommendations we make, we aim to improve healthcare systems and processes in order to reduce risk and improve safety. And we also make safety observations and record safety actions taken by organisations during the course of any of our investigations.
Thank you for that. I think it's a really good explanation. And you touched on the difference between your approach and probably a local investigation, but what are the big differences between an RCA that's done at a local NHS organisation and one that the HSIB does?
So RCA, root cause analysis, could be described as a more linear model that seeks to identify causal and contributory factors, so a more restrictive cause and effect approach. In the past, we've seen evidence to suggest that learning from these is restricted to individual staff and organisations, and in my personal experience, as I alluded to a moment ago, the ability for patient safety teams in healthcare organisations to make meaningful systemic change is limiting and frustrating. And HSIB have a unique opportunity, I think, to influence this. And we do that we use a reference case as a window into the patient safety issue. We'll investigate the details of incidents using structured analytical models to identify the key lines of inquiries to be explored as part of the national element of an investigation. We have what I think I'd describe as a toolkit of approaches. So I've got my little toolbox that we can use to investigate an incident. And sometimes a blended approach can help us confirm and challenge our thinking. So not necessarily just using one method of analysis. As a national team, we operate under the principles of safe space. So that enables the staff and the families, the people that we speak to speak to us in an open manner with the investigation team without what they've said being shared with their organisation or with other external bodies. There are obviously caveats to that. For example, a coroner may request access to our interviews, and obviously in those cases we do give them, and we share that information with our staff when we're undertaking interviews. But it enables us to get a really clear understanding and hearing those individual stories from both families, from staff directly involved in the case, where being offered a statement can give you some information, but actually having that conversation and understanding exactly what happened from the start of their involvement with the individual through to the end point, it can be really informative and enable us to dig deep into some of the complexity that's involved in an incident.
The difference is an RCA, as you said, tends to be quite a linear process. It's almost kind of a single tool, and you take the context of what you're investigating into consideration and apply what you feel are the best elements of your toolkit to that to come to a very broad and complex, I guess, conclusion, more nuanced.
Yes.
Okay. Yeah. So obviously there are an awful lot of things that you could investigate, and I mean, I have to say, since I've been watching, I've seen a lot of investigations kicking off and a lot of ones being completed. So how do you decide what you are going to investigate?
We consider potential incidents or issues for investigation based on wide sources of information, including that provided by healthcare organisations themselves, our own research, and analysis of patient safety systems. So anyone can report an issue to us. For example, we do get referrals from members of the public, from families, from patients themselves who feel they've been harmed, and from trusts and healthcare staff, as was the case in the NG incident. Mm-hmm. It's important to note that the national team, so in my role, we don't replace a local investigation, and we cannot investigate on behalf of families, staff, organisations or regulators. We do use strict criteria to assess topics and risks. And those three criteria have a subset of sub-criteria. So we look at the level of harm and potential harm. We look at how prevalent the issue is in the NHS. And we looked as to see how much value HSIB can add to the learning in that area. And we have internal panel processes in place that assess potential safety investigation cases against that criteria that we have in HSIB, and decide what to do and what to investigate in that way. And as you can imagine, in the last sort of 12 months or so, a significant focus on COVID-related issues.
When we look at the NG related investigation, what triggered that?
Without wishing to repeat the report, I'd say have a good look at section 3 of the report. So if anybody listening hasn't seen the report, it's on our website, and our website is www.hsib.org.uk, and you can actually see all of our completed reports and also interim bulletins of reports or announcements of investigations that we are starting. So it's quite helpful to go onto the website. So I'd refer you to section 3 of the report. However, in summary, a medical registrar raised concerns about significant harm experienced by patients as a result of misplaced NG tubes. And so we were aware that there was an issue, and we looked at the patient reporting systems, and we started this investigation after we were informed about the case of Fabian, a 26-year-old man who had an NG tube accidentally placed into his lungs whilst being treated in a critical care ward after a cycling accident back in 2018. And
I have to say, it's a really quite an engaging way of following an investigation through, having that reference case in there to make some of the things, if you like, real. I think they land really well because of that. Does every HSIB investigation have a reference case?
In the national, yes. Okay. So the national team, we have a reference case, and we explore that patient's story. There are other investigations, and I'll refer to potentially later on another investigation report that we've done, which looks at more thematic analysis. So it may not be a specific patient safety incident that we're looking at, but a thematic analysis of things that we are seeing on a more regular basis. So, for example, we've had a never events report that's been published that looked at all of our learning from the individual national reports that we had achieved. So they don't have a specific reference case because they are more of a thematic review of what we've already considered. I suppose it's just an opportunity to thank really those people that and their families that have been involved in an incident, and the fact that either patients themselves, or unfortunately if those patients are no longer with us, their families enable us to share those stories. It really does, as you say, offer a powerful window into an individual event that can then be seen to be looked at through a national lens. So we are very grateful to those patients and those families that give us their permission to use their story.
Yeah. Now, if we look at the NGT investigation, without going through it all again, because as we said, people who are involved with NGs really should read it. It is a fantastic piece of work. But when you had completed it and when you started reviewing your findings, were there any findings that surprised you?
Yes, and I suppose one of the big things for me, so my background is in nursing. I'm 30 years NHS. I hate saying that, makes me feel very old. But I'm used to inserting nasogastric tubes, but I hadn't necessarily understood the variation of pH paper testing strips. So different manufacturers have different colour coding for classifying whether it's safe to feed. So there's variation in the colour. There's also variation in the number of pads. So you can have a manufacturer that's producing pH paper with 2 pads to cover, a manufacturer with 1 pad to cover, or even the same manufacturer with different amounts of pads to cover. And I suppose that variation was a surprise to me. And also the procurement processes. So you can have in any one hospital, and as we found in the incident that we investigated, suppliers from different manufacturers in the same organisation, which obviously can lend itself to error occurring. So I suppose that was my biggest surprise, was the variation in pH testing paper.
Okay, I mean, having worked for an organisation in the past that was a manufacturer, it was always very interesting when we transitioned hospitals that people, we had to spend a lot of time on something as simple as this is now the pH strip and this is how you read it, because sometimes you actually got a situation where the colours between different papers were reversed. So what would have been below 5.5 on the old strip was now above 5.5, and people had to really readjust their thinking, because I guess in a clinical situation when you're doing this often, you kind of eventually know what under 5.5 looks like, and they had to start rethinking that again. So but I have to say, one of the things that did surprise me was the amount of variation you found in the investigation. So I think it was really enlightening to me to realize what a significant problem that could be. And at the end of the day, it's not really, as you said, it's a procurement thing. It's not necessarily a clinical thing. If only one strip's used in a hospital and there are barriers in the way of others being used, that should be removable. But I guess, if people are using non-gastric aspirate pH strips as well, which would legitimately, which would be legitimate for them to be in, because people need to do urinalysis and other tests, then it's hard to remove it altogether. So it was really that, and I think the depth you went into on that on the report was really quite fascinating.
Yeah, and I think we allude in the report to some of our observational work that we did, where a nurse shows us how to read a pH strip, and actually she was showing us something that was not dissimilar to reading pH on a urinalysis strip, because the particular strip had I can't remember now, 2 or 3 pads, and she said you only need to read the top one, which was really interesting.
Yeah,
again, goes back to how are you taught, how is your competency assessed, and the nurse was so willing to show us what she was doing, and she was so helpful. I mean, obviously we did explain afterwards what we'd seen, and my heart went out to her, actually, because she was just what she'd been told, but it just shows how incidents can happen in healthcare if we've not got the right resources available to us.
And I suppose continuing on from that and thinking about the current methods of NGT position verification, what's your impression of the confidence clinical staff have when they're using those existing methods?
So my personal experience is that there is a level of anxiety in both testing using pH and confirming using X-ray interpretation. I remember many years ago being involved in an incident investigation regarding a lady that had a feed started after a junior doctor had said it was safe to feed following review of the X-ray, and very sadly that lady died. And that investigation was many years ago now, but I always remember that one. So I have a personal anxiety, and obviously we know from the figures that are in the report that X-ray interpretation it isn't 100% reliable. In fact, it's one of the incorrect interpretation is one of the biggest errors in NG tubes being misplaced into the stomach and people having their feed started. From an investigation team perspective, our experience from undertaking this investigation is that confidence levels were variable based on the frequency of insertion, the training that they'd had, the experience that they have at inserting NG tubes, so where they work. So we found generally in intensive care there was a greater level of confidence because they were used to inserting nasogastric tubes, they were used to checking NG tube position. And from a medical staff perspective, if a tube was considered to be unknown, whether it was in the right place, if it didn't meet the pH criteria, or there was any uncertainty, there were doctors available to authorise a chest X-ray or an X-ray to confirm NG tube position, and then obviously read that X-ray. What I found also personally, I've not shared with you that during COVID wave 1 and COVID wave 2, I worked in an intensive care unit, and saw numbers of NG tubes inserted. I personally didn't insert any myself because whilst I did some training to update my skills, I didn't think it was safe for me to be inserting NG tubes. I've practiced so long. However, we had many conversations with clinical staff about NG tube verification, and there were incidents where I worked, and there were near misses, and we talked about the confidence level, and there's certainly from a nursing perspective there was greater confidence in NG tubes being confirmed by X-ray. However, there was amongst junior or trainee doctors, they preferred it if they had got the confirmation from the pH strip first and did not need to use the X-ray, because obviously on ITU you got all the wires. What was really interesting was the staff that were coming from different areas to work on intensive care. So they were coming from outpatient areas, coming from I don't know, a tissue viability nurse, for example, that perhaps hasn't done NG tube insertion for quite some time. and you're all part of a multidisciplinary team. And so obviously there were fears associated with those types of staff working in an intensive care unit.
I think that's really interesting that you're saying the nurses are happier if there's an x-ray and the junior doctors are happier if it's pH, because I guess it's somebody else, the other person's taking the decision at that point. So it's kind of, I think it reflects some of the conversations I've certainly had, is that if there's any ambiguity at all, people, or sometimes even if the pH result is under 5.5, people still send for x-rays because they don't want to take the decision. And what you found sort of backs that up. It's kind of let somebody else do it because the people do have concerns about the current methods.
Yeah, and I suppose so. The investigator, we didn't explore that in great detail in terms of confidence in decision making. It was just some of my observations when I was working clinically. So I take that as a personal sort of observation when I was working on intensive care.
Yeah.
But absolutely, I think what we know is that some hospitals, their first line was to go straight to X-ray. So. There is variability in how people interpret the guidance, which we know from the report. So I won't,
and I guess more recently, because of COVID, there was sort of recommendations from Baypen saying, well, if it's a COVID patient, X-ray them first and then go to pH testing. So we've probably seen some variation during COVID.
Yes.
So it'll be interesting to see what happens now. We're sort of coming out of that, and people will have had time to digest the report, because I guess the report landed at a time when we were in the middle of the worst part of the second wave. So that probably meant people didn't get to read it when they did, which is, I guess, good why we're having this conversation now, because hopefully we can bring people's attention back to it.
Definitely COVID impacted on it, because it delayed, because obviously I was working in wave 1, so it delayed some of the investigation. And then wave 2, obviously it was published shortly just before the second wave. But we do refer to COVID in the report, as you know. So
yes,
we refer to BAPED, who did a piece of work around exactly that. What do we do for COVID patients? So
now one of the things the report talks about is NG placement being a never event. And, you know, as the report says, never events are patient safety incidents that are considered preventable because national guidance or safety recommendations that exist that provide strong systemic barriers which should have been implemented by healthcare providers, and the misplacement of an NGT that's used has been a never event for a number of years. And in the report, there are a couple of statements that might seem contradictory with regards to misplaced NG tubes continuing to be a never event. On page 9 in the general findings, there's a statement that says there are no systemic barriers to preventing feeding into an NG tube that has been accidentally placed in the lungs, which suggests that use of misplaced NGT should not be a never event. But then on page 22, it says the strong systemic barriers in the case of misplaced NG tubes are described in the 2016 patient safety alert and resource set. So those two things sort of seem to contradict each other a little bit. What's the view of you and the team with regard to the use of misplaced NGTs being a never event?
So I'll apologise if there's any confusion there. I think the quote with regards to the 2016 patient safety alert and resource set that was completed by NHS Improvement, as they were at the time, Dr. Francis Healy was fundamental in producing that very detailed resource set. And within the resource set, they refer to the strong systemic barriers. So I think it's an interpretation of how we've written the report. I think our initial where you're saying there are no systemic barriers to preventing feeding into an NG tube that has accidentally been misplaced into the lung is our stance. And I think it might also be helpful for me to refer you to a more recent investigation report. It's a national learning report recently released, specifically looking at never events. And in this national learning report, our previous never event national investigation reports were analysed, and they were analysed to look at the themes in the factors that contributed to these incidents happening. The analysis covered 10 never events, the analysis covered a number of never events, and in 10 never events of the report found that barriers were neither strong nor systemic. And these events are not wholly preventable and don't fit the current definition of never events. So that report has led to 2 safety recommendations to NHS England and NHS Improvement. And these are to review and revise the never events list and to develop and commission programmes of work to find strong and systemic barriers for specific incidents where barriers are felt to be possible but aren't currently available. And I think and contained within that report are the links to all of the never event reports. There's also another one relating to wrong tooth extraction. So I think it might be helpful for your listeners to have that report shared with them as well, because it does help shed some light, if you like, on how we perceive never events and what is really meant by a strong systemic barrier.
Okay, thank you for that. It's a really, really good explanation. It maybe you can't comment on the next question, but anecdotally, some clinicians suggest that despite being a statutory requirement, there may still be underreporting of never events involving misplaced NGTs. Did anything in your inquiry, or even perhaps in your experience, suggest that might be the case? So
the report talks about reporting to the MHRA and the yellow card scheme, and what we found there was that often that there was a mismatch between events reported and the yellow card scheme. But more generally, I think we often find problems associated with the equipment not being reported. And it does seem that staff learn to accept usability issues and then make workarounds. I think the system, and when I say the system, the NHS has set them up for increased likelihood of error in that case. And also, I think near misses, so events that did not turn into a never event but nearly did, they're not reported. So we don't know how often NG tubes are actually being misplaced in the first place. Because if detected before feed commenced, the trust are not required to report it. And then I think this limits our opportunity for learning from these events. And you touched then on my personal experience, and certainly that the latter point about the opportunities for learning from near misses, I think is huge. I think it's an area we could look at and think, okay, so that patient wasn't fed, so we're fortunate it's not an ever event. But actually, what were the conditions at the time? What can we learn? What were the influencing factors? How was the tube located into the tummy or wherever it into the lung or wherever it was? How did they identify it? And looking at it also, I really like appreciative inquiry. So when it works well. So what are the conditions? We insert a lot of, and we refer to this in the report. There's a lot of times that we get the NG tube in the right place and the checks work. Yes. What are the conditions that enable that to happen?
Yeah. Okay. I guess we do always focus on when something goes wrong, rather than looking at how often it goes right. And if you look at the published research, NGTs are, well, certainly on initial insertion, not that often inserted in the wrong place. So I guess people have limited experience. Some people may never have inserted one in the wrong place. And I guess if that does get picked up, it doesn't, as you said, it doesn't get reported. but that piece around what really does work the best, it would be a really interesting piece, because there are so many factors that must contribute to that. Sometimes clinicians, I guess, are placing or using NG tubes in quite difficult, high pressured, perhaps badly lit environments with a lot of distractions. So it would be quite a complex thing to have a look at properly.
Yeah. There is. I mean, we do the NHS. I know some organisations, Birmingham, for example, Leicester. There and there's lots more. So I need to be careful singling out organisations. But the learning from excellence. So there is work out there where trusts do recognise when things have gone well. But obviously, HSIB's remit is to is different to that. Although we do use methods to look at when it works well. For example, appreciative inquiry, not for this particular investigation, but we do use those models if it would be helpful to us to identify opportunities for learning. Okay.
And just finally, there are numerous recommendations, observations, and actions in the nasogastric tube report. Which ones do you think would have the biggest impact on patient safety with regards to nasogastric tubes if they were implemented in full?
I mean, obviously a design solution is the ultimate. However, my feeling is that we've tried to make recommendations and observations that cover all aspects identified, and if implemented should complement each other to cover the design, to cover the procurement, to cover the competency-based assessment of individual staff and groups. That there are interdependencies within the recommendations, and therefore ensuring the key stakeholders working together where possible will be optimal to ensure implementation of those recommendations. The key here, I suppose, is considering design and involving the key stakeholders, and that means involving the user as well, so involving patients, involving the organisations. Currently, I don't know whether you're aware, organisations are given 90 working days to respond to our recommendations.
Okay.
And these responses are published on our website. So whilst the 90 days from publications happen, we're in the process of that recommendations review. And it's important to say that NHS England and Improvement are also looking at developing process to follow up on the actions as they are being implemented as well. So for me personally, and I think I talk for the investigation team and indeed HSIB, I think when we make recommendations, the recommendations are all important, but they're often interdependent. They're interdependent of each other. So one affects the other.
Okay. So there is lots to do to increase the safety around nasogastric tubes, and it's not one group of people that have to do it.
Absolutely, and I think what I've personally found with this investigation, there's such an appetite. I've been working with, I won't name them, but I've been working with one of the recommendees, the lead, and his organisation and the organisations he's working with. There's such passion to do the right thing, and there's a real appetite to I mean, they've been very complimentary of our recommendations and our findings. I don't think there's anything new. I think maybe the pH issue was quite new to a lot of people, but they really want to make it safer. Yes. And so for us, it's making it happen really, and it not being just another report that sits on a shelf and doesn't get the leverage and the action that's required.
Yeah. I mean, I certainly, obviously, mainly talk with the nutrition community around this, and I don't think I could find a more passionate bunch of people around patient safety. It was one of the things I love about working in nutrition is the nutrition nurses and the dietetics teams and the MDTs that sit around them are so focused on getting it right and trying to make it better. It's I find it really inspirational. It might sound a bit cheesy, but I really do find those people brilliant.
Absolutely. And I think that's it. The radiographers, I mean, one of the things, a design solution, obviously there are some design solutions out there, but one of the key things in terms of X-ray interpretation is having experts that understand how to read an X-ray. And the Royal College of Radiologists and the Society of Radiographers have been absolutely superb and really galvanizing the radiographers who have the skills and competence to read NG tube X-rays to confirm position. Again, that they're so willing and wanting to make this safe for patients, and they're trying their best to create the conditions in which it could be a responsibility assigned to, for example, a radiographer. And that passion and that willingness is really heartening to see.
Yeah. Well, Nikki, that's all we've got time for today. I want to thank you for taking the time to come on and talk about the report. There are so many aspects of it. We could have probably talked all day, but no, thank you again for coming on. Thank you for leading such a great investigation, and really look forward to seeing what people start doing with it now that hopefully they're getting a bit more bandwidth and headspace to consider it and move things forward. But thank you for today, and good luck with the next investigation.
Oh, thank you for the opportunity, and my thanks to my colleagues in HSIB and also to everyone who contributed to the investigation. So really appreciate the opportunity to share. Thank you.
Brilliant. Okay, we'll speak soon. Cheers now.
Thank you. Bye.